Good afternoon. My name is Tara Sklar. I am a professor of health law here at the University of Arizona College of Law. I'd like to welcome you to our session today on LawCats Live. The topic is vaccine distribution and long-term care. Is it working? And I am really particularly excited about our session today because the College of Law has joined forces with the University of Arizona Health Sciences across all 4 colleges: medicine, nursing, pharmacy, and public health, to really talk about what's happening with the vaccine rollout. And we are very fortunate to have with us those that know exactly what's happening right now and what is about to happen with the vaccine more underway at a very granular level of detail. Here specifically in our county, Pima County, across the state of Arizona. And as you'll see throughout our talk, and you may have questions about this as well, in other parts of the country and even around the world with what's happening. Before I introduce our esteemed panel, I would like to recognize and appreciate Dean Mark Miller from the College of Law. He has been at the forefront of discussions with me about COVID-19 and what the College of Law can offer in terms of resources and support for our community here and abroad. We also have had tremendous support from our development team led by Megan O'Leary and Karina Uckland, and from the UA Health Sciences with Caitlin Armendez-Shergill. So thanks so much for all the logistical support to bring this session to you today. Some housekeeping is I'll just speak for a few minutes to set up the topic, and you can have Q&A throughout. There's a button at the function at the bottom of your screen. You can ask questions, and basically each of our panelists will speak for about 5 minutes, and then we'll have Q&A for another 15 minutes at the end. And then if it looks like there's a great deal to continue to discuss, then we can go on a little bit later after the 1 o'clock mark if folks are interested. And this video will also be recorded and posted on our Arizona Law website. In general, the panelists are going to talk about the barriers with the vaccine rollout. We know that it's been slower than anticipated in most areas of the country, but really, why is that? And what can we do in terms of those barriers, and how do we address them effectively and equitably? Those do not need to be opposing terms as they are often being represented, unfortunately. So we'll address that as well. And I'd also like to take a minute to specifically focus on why we're talking about this population. And it's because less than 1% of Americans live in long-term care, but 37% of the deaths at this point in time come from those facilities. And in some states, in New Hampshire, for example, which is at the highest, over 70% of the COVID-related deaths come from long-term care facilities. And in many states, it's over half. And so that's why we're taking the time to specifically talk about this population. But we also know that the majority of older adults aren't in long-term care facilities, and many people are wondering about their access to the vaccine as well. So we'll talk about that in turn. I know that we frequently get into these large numbers, and it can be scary and alarming about what to do. And so I just like to take a moment for folks who are joining us today to know that we're an ongoing resource. We're going to recommend what we think are trusted resources for further information, as we're still underway with how this pandemic is evolving. I'd now like to introduce our panelists. We have with us to start Dr. Kate Ellingson. She comes from the College of Public Health. She joined the College of Public Health just a few years ago, but prior to that, she was at the CDC and the Oregon State Department of Health for 10 years. Her research interests are specifically in infection prevention, and she has relevant expertise for us today because she's working with the Pima County Health Department on how to build local capacity for infection control in long-term care facilities. So I'll turn it over to Dr. Kate Ellingson.
Thank you, Tara. Thank you for inviting me to be here today, and to the other panel members. So as Tara mentioned, I'm an infectious disease epidemiologist, and my focus is healthcare. And I've really been interested in the long-term care setting and how we can understand what happens with infections in these settings and the best way to prevent disease spread. And as Tara mentioned, this pandemic has really disproportionately affected people who live in long-term care. And although nationwide, approximately 5% of the cases are in residents and staff and 37% of the deaths, it does vary by state. And as an epidemiologist, I'm interested in how those numbers pan out in Arizona and Pima. And in Arizona, it's actually long-term care is only 2% of our cases and 18% of deaths. In Pima, 3% of cases and 22% of deaths. However, I think it can be misleading to just look at that percentage because Arizona has also sort of led the nation and at some points in time the world in terms of our absolute number of cases per 100,000 population. So I think, our long-term care population is really especially at risk. Even though they may represent a smaller proportion of total cases and deaths, we know, and many studies to date have actually confirmed that when rates are high in the community, our long-term care population is at higher risk. And so that has certainly been the case here in Arizona, where we've had a lot of community transmission. And we know, that our staff at many of our facilities are extremely dedicated. However, staff members are the conduit from the community to the long-term care setting. And so, as part of the work that I do with Pima County, we work a lot with staff at long-term care facilities and try to recognize that they really are sort of under-resourced in terms of their abilities to prevent transmission. But we do know that staff usually are the ones that bring it into the community, into the long-term care facility, and then it can spread therein. And so that sort of brings us to this point of vaccination and, the challenges in these settings. And so, one of the things that we've been working on in Pima County is trying to figure out how to identify all of our vulnerable populations that are sort of living in congregate care. And so, one place to start is with the licensed facilities. So we actually, we know exactly how many facilities are licensed as skilled nursing facilities, which are really high risk. We know how many are licensed as assisted living. And where we've sort of had the most challenges in terms of like figuring out how big that population is figuring out how many adults live in sort of non-licensed group homes, how many elder people just need assistance in figuring out how to get a vaccine. And so those are issues that we've been dealing with in the county. So let me just go over a couple of the numbers nationwide. And I will say that if you're interested in kind of following the vaccine rollout, the CDC has a vaccine tracker, it's COVID tracker, and then you can click on vaccines and you can look at the number of doses distributed in long-term care facilities. Now, what they publish are the doses distributed through the Federal Pharmacy Partnership Program, which Dr. Nicole Henry is going to talk about in more detail because she's super involved in that. But in terms of the numbers posted, that means those are federally allocated doses that have gone out through commercial pharmacies, primarily Walgreens and CVS, but there are some other local pharmacies who are part of this. And they've partnered with the federal government to get vaccines directly to facilities. So they go to the facilities, they administer the vaccine, they take care of the consent forms, they bring the personal protective equipment needed. And so this has been sort of the primary, the starting point for us. So as a county, with Pima County, when I'm working with them, our first effort was to market this program to all of the facilities and say, please sign up. Because if you're signed up, in advance, then you'll be on a list, and CVS or Walgreens or someone from this program will help schedule you your vaccine clinics. And Dr. Henry will talk more about how those roll out. But so far to date, through this program, over 4 million doses have been administered. And so we have to put that into context with the currently available vaccines. Moderna and Pfizer require 2 doses. So we're going to try to, once we identify the whole number of people in need, you need to multiply that by 2. So there's about 1.4 million people in nursing homes, but over 8 million people who are in some sort of long-term care. So kind of very roughly speaking, we need at least 16 million doses out just to cover the residents alone. And that doesn't even include the staff. So we have a long way to go. But in Arizona, over 45,000 doses have been administered, and there are over 3,000 second doses that have gone in. So that's exciting. And our largest skilled nursing facility in Tucson just had its vaccine clinic yesterday. So I'm just going to speak briefly before we turn it over to our next speakers about how we are doing in Pima County. So, we have about 450 long-term care facilities, either your skilled nursing facilities or assisted. And we had 166 sign up for that federal pharmacy partnership. So all of our skilled nursing, there's only 26 of them, and then some larger ALFs. So Pima County started a really aggressive campaign to contact all of those licensed facilities that hadn't signed up, because if they hadn't signed up by a certain date in December, they weren't able to sign up for this federal program. So Pima County has reached out to 199 of them. and scheduled for their public health nurses to go do on-site vaccination, and about 107 of them. And we've got a contract agency on board to help with some of the others. So there's still 81 licensed assisted living facilities that the county has not reached. And so they've hired a new person dedicated to reaching out to these facilities. And that person's also going to start looking into, group homes and other settings in which there's older, vulnerable adults who may not be part of these licensed facilities. So those are some of the issues. And, as an infectious disease epidemiologist, I'm really interested in how these vaccine clinics roll out from infection prevention. So there have been some concerning anecdotal reports about residents gathering for the vaccines, which then puts them at risk, right? So figuring out how flow can be optimized with the vaccine clinics, and also promoting staff education in terms of, having one vaccine does not mean you're protected. You need to be 2 weeks beyond the second dose. And so trying to just ensure that the vaccine clinics themselves don't seed outbreaks. So I'm gonna turn it over to the other speakers, and I look forward to the discussion. Thank you.
That was great. Thank you so much, Dr. Ellingson. Every time I speak with you, I learn something more about what's happening, especially in Pima County. But I do think what you've described is representative of the rest of the country, and that the skilled nursing facilities, which tend to be nursing homes, what we're more familiar with, are more operated by medical staff. There's been an easier transition with Operation Warp Speed and CVS and Walgreens and getting signed up, but the vast majority of long-term care settings are in more of assisted living centers, which don't have that medical personnel background. And so I think the situation you described in Pima County represents what we're seeing across the nation. So when we're talking about what is happening with the rollout in long-term care facilities, there's a big difference between skilled nursing facilities known as nursing homes and those that are the assisted living centers, which often have a lot more personal aides and caregivers and less actual trained medical staff. So I just wanted to highlight that in relation to the rest of the country. And when we hear criticism about what's happening with the rollout, where it's targeted and how to work on it. So those proactive efforts by Pima County are great to know about. Okay, so I'll turn it over to our next speaker, Dr. Nicole Henry. Comes to us from the College of Pharmacy, and she is also a pharmacy manager for CVS. So just really fantastic to have both sides of what's happening there from an academic as well as industry perspective. She has experience in the community pharmacy setting, hospital pharmacy, long-term care, and geriatric consulting. She really focuses on building and developing high-performing teams to serve a diverse patient population, particularly among older adults, and ways to decrease barriers to care. She has a great deal of experience in coordinating flu clinics, especially with healthcare students. And now I know we're looking forward to hearing how that's going to work with COVID. So Dr. Nicole Henry, welcome.
Thank you so much, Tara, for inviting me to be here, and thank you all for joining us today. So I'm also a part of the COVID vaccination rollout for CVS Health in the Peoria area, as well as Flagstaff and the outliers. I also learned today that we have vaccinated 32,000 people with CVS Health alone in Arizona. So our skilled nursing facility and assisted living facility rollout has largely been an incredible success. So we're super proud and happy for our teams and the work that they're doing in the community. In terms of the rollout, we are following the CDC guidelines for the ACIP recommendations. So we're adhering to that with phase 1A, 1B, and 1C. I'm sure everybody's familiar with those, but in case you're not, 1A is for healthcare workers, residents, and staff of long-term care facilities. We've actually seen a huge turnout with the residents and also the staff at these facilities. 1B is the frontline essential workers and adults 75 years of age and older. And 1C, which we have not entered into yet, adults 65 to 74 years of age and individuals 16 to 64 with high-risk medical conditions and other essential workers. Currently, we're still in the beginning stages of the rollout with the SNFs and the ALFs, the skilled nursing and the assisted, but we do hope to expand that to the full general population in May or June, depending on when the governor allows us to move forward with this.
Okay, great. Thank you. Nicole, did you want to mention at all what's upcoming with the colleges and the rollout and more rural areas?
Yes, absolutely. So I'm also heading an initiative here on campus at the University of Arizona College of Pharmacy, which is a partnership with the College of Public Health, the College of Nursing, and the College of Medicine as a way to get vaccines to our underserved communities in the area. So we'll be using mobile pod units to go to different houses of underserved communities and make sure that they can get the vaccine. And this is also a great learning opportunity for all of our students who are immunization certified. They'll be able to help with the rollout under the direction of a preceptor. So we're super excited about that. And if anyone would like to sign up, you can to help out, just a shadow. Yep.
Oh, that would be great. Yes, this could be a great opportunity if you would like to know how to volunteer and throughout Arizona. Please contact us. You can do so with the link in the registration page, and we'd love to hear from you. Or even in the Q&A, you can leave your email, and I can try to keep track of that. It's really these local community efforts. I feel like are hard to find out about. So I'm glad that you're raising attention to them. I'd now like to turn it to our College of Nursing, being represented by Dr. Lori Martin-Plank. Sorry, my text is there. Sorry, still getting used to the Zoom layout here. Dr. Martin-Plank is a nurse practitioner and a clinical faculty member at the College of Nursing in Tucson. She does work remotely from the state of Pennsylvania, so she will likely share with us what she's also seeing in her home state, as well as what she knows is happening here in Arizona. She teaches in the area of health policy, clinical geriatrics, and primary care. Her recent clinical practice is in long-term care and home health care, house calls for older adults. It's my great pleasure to introduce Dr. Lori Martin-Plank.
Thank you very much, Tara, and thank you for inviting me. It's really exciting to be here. So I'd like to speak from the nursing perspective. And as you know, throughout the whole COVID epidemic, nursing and medicine have both been on the front line. And certainly long-term care has been the front line of the COVID pandemic. So from a nursing perspective, communication with all levels of personnel is vitally important, and it's a real challenge. And that is because there are really bizarre staffing patterns. Frequently, the nursing homes they contract for what you might call them certified nursing assistants. We now refer to them as direct care workers. So a lot of those positions are contracted out with outside agencies. So getting the message out can be problematic. And even if the message is disseminated to the administrative types, there's no guarantee that it is going to get down to the level of the direct care workers or the nurses who really need it. And many of them are part-time or per diem, which is another challenge. So some facilities that are not associated with large chains, and Tara referred to skilled nursing facilities or SNFs, which we call them, they also have, in addition to the skilled nursing facility, they have a lot of beds that are called maintenance beds, that most of the patients there at some point have to go on Medicaid because they spend down all their earned money from working, and then after that they have to go on Medicaid. So that is a large part of the long-term care industry, in addition to the less regulated and a little bit more what I would call loosely organized assisted living facilities. So the small facilities that aren't, affiliated with these large chains, and I think Kate was referring to some of them, it's hard to get the message out to them sometimes about the vaccine. And if you miss the deadline, it's difficult to get the residents immunized. So that's another problem. And I'm glad to hear that we're doing some marketing in the in the Tucson area related to that. But it's a problem nationwide. And I don't know that we're doing the best job, in every state. So the other thing is buy-in by nursing administration and relationship management is very, very important, especially since this is a voluntary effort. And communication with providers who see residents in the facility is another communication issue because, bigger facilities will have a medical director, smaller facilities will just have either physicians, physician assistants, or nurse practitioners going in to see the patients. It's not a well-organized system at all. So trying to communicate with all of them is another challenge. If they work for, and many of them, like myself, when I did it, for a while, I worked for Optum, which is Optum Clinical Services, which is part of United Healthcare. They're one of the largest providers of long-term care services for their patients in the long-term care setting. So again, you have fragmentation because the long-term care setting isn't owned by United Healthcare, but their patients who are residents there are served by their providers. There's a lot of misinformation about the vaccine, and we have to do a lot of work as far as combating myths and fears. Many of the direct care workers are not fluent in English, and they may have difficulty with written information. So using pictorial handouts and small group sessions can be particularly helpful. And I know my work with some of them or who are Hispanic in the Pima County area, we recently did a project with caregivers of older adults, and we developed, it's called a graphic novella, which is like a little comic book, and it's translated into, it can be in English or Spanish, and it talks about some of the issues, and it kind of, they're emotional issues, but it talks about them in a way that the caregivers can kind of laugh about them a little bit and identify with them. And hopefully we can drive home the point of what the resources are. So using tools like that with the Hispanic population who are direct care workers specifically may be helpful to get the message out. Also, identifying an informal leader or champion among the direct care workers at a facility can really go a long way to getting others to, kind of like buddy up and go along with it. So that's another way to do it. And the other thing that's really important about that is direct care workers, they have a very hard job. They don't make a lot of money, and they're really not recognized for the value of what they do in many cases. So, identifying one of them as a champion, somebody who has taken the vaccine, really goes a long way to get a whole bunch of them to, follow suit. Another thing is prompt damage control when a resident or staff member suffers an adverse reaction. And that's very important because you want to minimize it, you want to normalize it, and you want to reassure them that this is not something that everybody is going to experience. And in most cases, it's short-lived, maybe 24 to 48 hours. Another thing that is being done, I think, to help with the rollout that I've heard of is that in facilities where patients, residents, and staff are getting their second doses, that they're kind of circling back to those who declined the first dose to say, we're offering you a second chance. Have you thought about it maybe and reconsidered? We're here to, to immunize you when you're ready. And I think that's very non-judgmental. It gives them an opening if they've reconsidered. Communication with residents, family members, power of attorneys, and guardians. And the latter two can be some of the most problematic, because in many cases, patients can't consent for themselves if they are deemed incompetent. So you have to go to the power of attorney, or you have to go to the guardian. And at times it's difficult to locate them. The other thing that's happening is patients who are in subacute or rehab facilities are sometimes missing out on the doses. They may have come after the first clinic was there and they've left before, they've come back again. So we have to follow up individually and help them to find another way to get the vaccine. Another thing that I've heard of, and this kind of troubled me, but it's probably a regulatory issue. A patient who was rehospitalized, they had had their first vaccine. They were in the hospital when the second vaccine was due, and the hospital refused to administer it. So hands up, but it's probably a regulatory issue. So they're the most things that I've heard about. I will say in the Philadelphia area, I'm sure you've all read about the debacle with the city health department and the young people that they hired to give out the vaccines, and some of them were diverted to friends of theirs, unfortunately, resulting in the resignation of people in authority. But what you probably haven't heard of is in our area in Philadelphia, most of the direct care workers are African American. And there's a coalition of Black physicians in Philadelphia who have been front and center, demonstrating they're getting the vaccines, going into the community and talking about the safety and efficacy of the vaccine. And I think that is really going a long way to convince those people who have some mistrust about the healthcare system to take the vaccine. I think that's what I have to say. Thanks.
Oh, that was wonderful. You covered a lot of territory there, and I really appreciate it. I think that's very helpful. I'll now turn it to our last panel speaker, Dr. David Beyda. He is the chair and professor in the Department of Bioethics and Medical Humanism at the University of Arizona College of Medicine in Phoenix. He is an accomplished medical educator, a critical care physician with more than 40 years of experience. And what's interesting in relation to our topic today was in pediatric critical care bedside ethics. He teaches ethics courses throughout the MD curricula, and he's also in the process of creating a new Master's of Bioethics at the University of Arizona. So I now turn it to Dr. Beyda. You're on mute. Yep.
Thank you so much. This is really a very important webinar, and I thank you all for putting it together. I'm going to come to this area from not only a physician side, but from a medical ethics side, and see if we can identify where the collapse is in getting these vaccines out. So what I'd like to do is offer an opportunity to consider the vaccine program as a three-legged stool. And each one of these three legs is important in order to hold up that stool. So the vaccine program is a three-legged stool. One leg is the number of vaccine doses. The other leg is the distribution of the doses. And the third leg is the prioritization of the doses. If any one of those legs fails, the stool collapses. The vaccine program collapses. So let's look at the ethical issues with each one of those. Let's talk about the first leg, which is the doses, vaccine doses. Well, clearly there is not enough. And what is happening is that there is a charge to try and vaccinate a lot of people with not a lot of vaccines. And some of the ethical issues that have come up that I know many of you have heard are things like the tag-along or the jump in line that we have heard. And the question is that ethical? Is that something that should be? Should you even take it if it's offered to you? So let's talk about the tag-along. Say you are 40 years old and you're driving your parents who are in the 80s to get a vaccination. They get vaccinated, and because you're in the car, you're offered the vaccine. Now the question is are they giving you the vaccine because there's extra, and they're afraid they're not going to have any, that they're going to have some leftovers, or is it because it's convenient? Now, if they think they're going to be leftovers, then that's a little different story. But you don't know that. You don't know that, and it's the middle of the day. You don't know what's going to happen at the end of the day. The jump-in liners are those who are taking care of themselves, and the ethical issue behind that is this self-service really something that one should do? So the vaccine doses amount is really a big key. So that leg is marginal right now. Let's look at the second, and that's the distribution. When we look at the distribution, we find that, for example, there are areas that are not really considered. They're struggling to get out there. Rural areas, many of the rural areas over there in the Native American areas as well, the diversity and equity communities, those are just beginning to come up, but they weren't really considered as top priorities in the very beginning. So that leg is marginalized. And then the prioritization. Well, we all know that healthcare workers and all of the frontline workers are really in need of having that protection. And then there's others and teachers as well. But where was the prioritization for the more vulnerable, the elderly in long-term facilities, and even the disabled? Right now, there is no prioritization for the disabled community. Without there should be no limitations on age, et cetera, et cetera. So that area, the prioritization, is an issue as well. So that leg is compromised. So when you look at the total vaccine program, it is very unstable, and it could collapse. But there's effort to try and at least fix those legs, at least put some Band-Aids on it and give it some reinforcement. And I hope that will be the case. But many times we're asked from the ethical perspective. Let's say you don't have any comorbidities, and you're not in the age category, and you are offered the vaccine. Should you take it or not? Well, the issue is, if you don't take it, you're not really sure where it's going to go and who's it going to. If you do take it, then your own moral foundation, your own ethics kind of drives that. And that's where that protection of self comes into play. So we're beginning to see, as we move along, that there are times when tag-alongs are offered a vaccine, but it's not consistent. It depends on the time of the day, who's there, what is being offered. And so if you're going to do tag-alongs, if you're going to get vaccines that way, then you need to let everybody know that that's going to be the case. So it winds up being really kind of an area of moral distress that leads to moral injury, that we are sitting here thinking, I'm not so sure I understand why things are going the way they are. I hope now that as we move forward, the long-term care facilities with the elderly and the disabled will wind up receiving the vaccines that they are entitled to. And the disabled group, either young or elderly, are really considered vulnerable as much as anybody else when we talk about comorbidities. So from the ethical perspective, those are some of the things that we deal with when we're asked as ethicists, what would you do? From the physician side, I mean, of course, we're looking at how can we vaccinate as many people as we can, and add the caveat to that, do it ethically and morally sound. So there's a lot of work to do, and I'm just hoping that these three legs become reinforced by getting more doses, by having a true appreciation for equity and diversity distribution, and the prioritization of those who truly are vulnerable and who are in need of it. So I thank you for that, and I think those are the issues that we deal with from the ethical perspective and from as a physician.
Oh, that was very helpful. Thank you. And as you were speaking, we've gotten a few more Q&A from the audience rolling in. Before I start the process of reading those to our panel, do the panelists have any questions for each other or points they'd like to expand on? Okay, I think that actually one area that might be of interest that's related to a question that came in goes to Nicole. It would be about the mobile clinics that are heading out and really how you're trying to reach both underserved and older community. What is the logistics behind how you're doing that? Because the audience question was about the digital divide, that we're all very aware of what's happening in terms of trying to sign up to get access to the vaccine. Could you expand on that for us?
Sure. So the College of Public Health has a map of pretty much all of Maricopa County and some of the outlying areas that we'll be targeting for COVID vaccinations. All the registration piece is done online, which is a barrier to care right there, but they're also able to phone in. There's an option to give a phone call to a representative at each one of the colleges. We have ours right here at the College of Pharmacy, Alba. So she fields those phone calls and she helps everyone get set up, enters in all their insurance information, and ensures the adequate billing. As everybody probably knows, the vaccine is free of charge, $0 for everybody, but we do have to make an attempt to bill commercial insurance or Medicare first, and then we must bill through the HRSA government plan. So she ensures all of that. It can be really challenging for somebody to log in on the computer, and that's why we have the phone line that's open.
Great, and actually related to that, we had a question that came up. Is there such thing as an on-call list where they know you have this list of individuals that would like to get the vaccine and just waiting to be notified?
So we don't have an on-call list at this time, but I can definitely speak from the clinics that we've had in the community at both SNFs and ALFs that if there is any residual vaccine left over, it does go to those that qualify in that 1B category, or might be a resident or might be a family member of a resident in that same age group. So this does not go to friends and family. It is not a free-for-all. It's nothing like that.
Great, thank you. I think the other area that, Laura, you started to address with the pressure on direct care workers, and I know this is something that Kate, you're looking at too with occupational health. Do you have any thoughts, like as we go forward, there are widespread vacancies across the country, and especially in Arizona, with filling those positions? It's a high-risk job, it's low paid, it's hard work, and this might be something where we need to have mass inoculations regularly. I just love to get your thoughts on our workforce and long-term care related to the vaccine rollout.
Well, I would just say, long-term care, even before the vaccine rollout, was kind of a fragmented system, mostly understaffed. And although it is one of the most highly regulated settings in healthcare, my personal viewpoint is that does not guarantee quality care to the residents. And we really, if one thing has come out of this pandemic, I think it is that we need to re-examine our current long-term care, quote unquote, system, and look at other countries and what they have done with and for their frail older residents, and see what we can do, to model some of those things. But the other thing, I did look, at the, I know President Biden is going to increase the basic wage, the minimum wage, but that's not really going to help the direct care workers. They're probably about $2 above that right now, but that's still really not enough to eke out a quality existence. And I think the other thing is the undervalue. They're so undervalued. They really are. And that in turn, I believe, if you don't feel like what you're doing is worthwhile, and it's a very hard job, then there are implications for the people that they're taking care of also. And that's just, I'll leave it at that. Kate.
I would completely agree with everything you said, Lori, and just, I'm excited about some of the general statements about, more funding to address occupational health at a federal level, but also funding to state and locals. But I do have concerns with long-term care for some of the same reasons you mentioned, and that, a lot of direct care is provided by individuals from vulnerable communities. We know this from, data. And many times, and we've also seen the impact in the pandemic of people having to work multiple jobs, sometimes at multiple facilities, which increases risk to residents too. And so I definitely feel like that, we can both help in terms of, I think addressing the direct workforce issues will, enhance the quality of care for residents, but also enhance the lives of these individuals. And we have some issues here on the, some specific local issues in Tucson with, as you mentioned, there's sometimes language barriers, and there are people working at these high-risk facilities who live in multi-generational homes, so vulnerabilities among the elderly residents of their own home. And so I hope we can take a closer look at that and see our charge as addressing not just the care of the residents, but the care of the caretakers as well.
Oh, that's great. Thank you so much for those responses. And I do know that 1 out of 5 direct care workers work in more than one facility, whether it's a long-term care, home health care, or in a hospital setting. And there's some studies done that have traced infections in long-term facilities back to workers working in multiple facilities, all related to salaries and wages and access to benefits. So it's at the core of why the spread was so rapid in the first place. Okay, so this is so exciting. We have a ton of questions. We are also at the close of our official time, which is 1 o'clock. So I don't want folks to feel obligated to stay on unless they would like to. But our panelists have kindly agreed to stay on for a few more minutes after 1 o'clock, and you are most welcome to join us. I do have a quick announcement that we have our next LawCats live on March 4th at 5 p.m. in Arizona, so save the date. And to check out the alumni and events page at the law school if you're curious about these webinars going forward. They tend to cover a great range of topics. So thank you so much for joining us. Please fill out the survey on today's panel. We'd love to hear from you. And I'm gonna, God, we have some great questions. I'm gonna ask a few more questions to our panelists. And I just have to acknowledge the range of the questions. I think it reflects the great deal of general confusion and anxiety and just around what to do now. It's so great the vaccines are here, but how do I get a vaccine? How do my parents get a vaccine? When does my kid get a vaccine? When are schools going to reopen? What is the ethical way to view access to the vaccine? So it's incredible. And I haven't even gotten to, the news that a third vaccine, potentially with Johnson & Johnson, might soon be coming out our way too. So talk about a lot to cover. So please continue to stay on. I'm going to ask I thought one of the questions that came in was really a great one for Dr. David Beyda to get to. So this is, since we have incomplete and changing data about the effects of the pandemic, how can we prioritize the prioritization that you're getting to in your three-legged stool that's fair and clear, but as well as flexible and responsive to what we're seeing?
Thank you for that question. I think it's a really important and great question. And so I'm going to kind of step out on a limb. What we really need, which I don't believe we have, is a core group of professionals who are expert in multiple areas who would meet every day. And we're talking about medicine, public health, epidemiology, nursing, the population advocates, people from who would look at the data every day and look at what can they expect is going to happen and anticipate some of the things. Now, they may not be 100% correct in their anticipation, But if they start doing this every day, maybe even twice a day, I mean, the data is coming in very quickly. There's a very good chance that this group who meets can really put together an assessment of where the prioritization needs to go, where the distribution needs to go, and at the same time have an education product that would help the public understand that this is a moving target. Right now, it is simply just, it's a train that's just kind of going forward, and who knows when it's going to stop, and can it pick up passengers or let passengers off? So if we had that group, I think it would make a big difference. It's kind of like a think tank. It's an advisory group. Let's look at what happened last night. Let's look at what's happening right now. Let's look at what can we anticipate that's going to happen this afternoon. Let's move these mobile units here. Let's change some of the things over here. And people may not understand that that's the way to go, but that's where the education comes in. But in other epidemics and other pandemics, in triage, in areas of triage, that's what's being done. They triage. We need to go over here, and let's kind of move away from this side. So I hope that answers the question. I'm hoping that we may get to that point one day.
And I think that type of multidisciplinary team and the triage model, it all seems a more responsive approach than what we've done thus far as well. And actually, you have all such incredible clinical and background medical expertise. And Laura, you brought this up in one of your points, but there's a lot of concern about the second dose and the efficacy of the second dose if there is delay in receiving it. There's a lack of data, frankly, in knowing that. But it's obviously an issue that people are concerned with, especially those that have had a first shot, whether they're going to be able to access the second shot if supply is in question, or the scenario that you laid out, Lori, where someone's hospitalized and they missed that window. Could you guys possibly speak to that? It'd be great to get more information out.
I have to say, I just follow what is going on, which seems to, depending on your source, you get different information. And my concern is that some of it is motivated by, trying to just get the first dose into as many people as possible. I mean, I heard out of Britain, they're mixing doses now. They might have had a Pfizer for their first dose, and they're getting a Moderna for their second dose. That's happening. Whereas the evidence, there is none that I'm aware of. Maybe Dr. Beyda knows, but I don't. Then I've also heard that it's fine to delay it, the second dose, by even a couple of weeks, that it won't make any difference, but I haven't seen any evidence about it. So anybody else want to chime in on it? Go for it.
Just the combination of the two vaccines, Pfizer and Moderna, that's being looked at. There's no data on that just yet. So people are given a choice. If you had the Pfizer, we've got a Moderna available. Would you like it or not? So if they do, those individuals are being tracked. And so we're not really sure where that's going to wind up and how that's going to play out. So, this is a moral and ethical question for each of us individually. If you know that there's not going to be a bunch of vaccines available by the time you get your second, you need your second, and and you're told, well, we've got some extra Moderna, would you take it or not? And many people would say, you know what, I'll take a chance. I'll do it. I'll take a chance and see what happens. So that's kind of where people are headed right now, and that's a part of the self-protection that we have from our environment and our culture and our ethnicity and our ethics and our moral foundation.
And I'd like to comment on that as well. I did see that the CDC approved mixing of the vaccines if we're not able to get two of the same manufacturer. So that's something that they have announced. And that's also a protocol that we do go by. So if somebody got Pfizer initially, we can give Moderna for the second dose since we have Moderna. The doses should be separated. by that 28-day window, but we can extend it because CDC also comments and says just get 2. Doesn't matter the window entirely, but we're looking at 2 doses total. We're not repeating the series. And the very first dose is 80% effective right off the bat. So you're actually getting a huge level of protection initially. That second dose just brings it up to 94.
Great, thank you. I did think it was really promising what came out of Israel the last few days, where they've done, so far to this point, it's really been clinical trial data, but Israel's been able to inoculate about 1/3 of their country. And so we're seeing more large scale, real world evidence with a large, just general population. And the results for the folks that are of the 65 and older age group seems to be it's a 91% efficacy, and they've only really used the Pfizer vaccine in Israel. But I think that that's such a neat, neat is not the right word, but it's something to watch. And because, a lot of people are in the wait and see camp, there's certainly a large anti-vax movement, and the 91% efficacy for an older population and that's not in a clinical trial, but just generally receiving it. And of that group, 0 had any type of severe reaction if they did become infected with COVID. It was all mild cases. And I think that's really what we're trying to prevent. My understanding is severe illness and death, and that's why we may see people, as you described, Dr. Beyda, with maybe I will take that second shot, even though it's not the same one I just had, because I don't want to have a severe case of COVID if I do get it. Kate, did you have a thought? I noticed you came up.
I just had a couple of thoughts based on what Tara brought up and following on the other speakers' comments. I think with the side effects, it's sort of paradoxically we think, oh, older adults are probably going to have more side effects, but we actually see individuals under 55 in part because of the more immediate ability to mount an immune response. They are experiencing some of these side effects. So I think that's an important message to get out to staff, especially at some of these facilities that are obviously in general younger than the residents. And then the other piece, I agree, Tara, it's really going to be critical to follow the older population as they're vaccinated, at a population level, because the trials included people over 65. But if you really get down to look at those strata, Pfizer reports over 65, but when we think about a lot of our assisted living and skilled, we're talking over 85. And Pfizer reports on a very small strata over 75. We're not totally sure about it appears to be effective, but I'd like to see thinner strata with some of those older groups, more robust. I think the other piece is because there's a little bit of a slower immune response mounted in the elderly. I think we're not really sure how protected they are right away. And I guess because I've seen some outbreaks in facilities post the first vaccination, I think we need to be careful in terms of how, just the messaging that you are going to be protected soon, but let's wait until you get some time after that second dose. So those are just some comments based on my experience.
No, I'm really glad you brought that up. That was actually in a piece out of, I think it was NBC out of Illinois and Chicago, where they were saying that there was this expectation that after they had the second shot, maybe within a few weeks, you could go to long-term care and see your grandparent or your loved one, your mother or father who's in that facility. And actually they were advising that would not indeed be the case. And it wasn't until we had more of a herd immunity across the country that could be. But I think that really surprised a lot of people. And I'd love to hear how you've been maybe communicating that, because that could be an incredible feeling of just, how much longer can it be before I can hug my parent or my loved one? Is there any kind of proactive communication about what's going to happen after the second shot?
I feel like everybody wants to know that, and there's not guidance from CDC yet. It's but across the board, and I get that question all the time. When can we start dialing back some of our mitigation measures? And we just don't have great guidance yet. on that. But I don't know if anyone else on the panel has some thoughts or predictions on that, but I'd be curious.
No, we provide counseling to everyone that this is not 100% effective. It's the best thing that we have right now after they do get the 2 vaccinations. And we do counsel the facilities, since we do 3 visits at every facility, that they may want to stagger that final visit as well because of that risk of side effects. So since we do the 3 visits, sometimes people might miss on the second one and we can make it up on the third. And that way the facility residents are cared for and the staff is able to care for them as well.
Okay, well, we are now wrapping the what is this, like the second part of our talk is wrapping up because we do plan to end at 1:15. Are there any pending thoughts that you'd like to share? Any resources? You know, some of the questions really to kind of focus around this vaccine hesitancy, where, you know, thoughts like you've raised, Lori, and about, you know, people starting the Pfizer and then going to Moderna and like what that could mean in terms of safety and efficacy. And it's almost causing something that had initial alarm anyway with the speed in which the vaccines were developed, which was remarkable, but then also caused concern because we'd never done it. It's unprecedented. So if you'd like to address that point, there were certainly a lot of questions around vaccine hesitancy. And then also if you want to share any resources, because this is a very noisy space, it's hard to know where to go for trusted information. I would say that my go-to is the Kaiser Family Foundation. I think it's a great resource. It's really clear, incredible mapping of what's happening in different states, and both in terms of specifically in long-term care. So that's my go-to. So maybe a final pending thought and a resource, and then we'll close out our panel for the day. Why don't we start in the order in which we did our, apologies, the order in which we did. So we'll go Kate, Nicole, Lori, and David, please.
Okay, great. Yeah, I mean, I agree. It's a very noisy space. I mean, I always check, you know, CDC recommendations. The Arizona Department of Health has a dashboard. For long-term care, there's some organizations like Leading Age and some others that have come out with some vaccine, you know, some materials to combat vaccine hesitancy that I can share with you, and then hopefully we can send to our group. But yeah, and I think Kaiser does a very nice job of summarizing the literature that's out there on long-term care facilities and COVID-19. So I think those are some great sites. Pima County is a little bit, their website can be sometimes hard to follow, but they do have that you can always go on there and find out what stage we're in terms of the, you know, the prioritization and where they are in terms of vaccinating currently. So that's also there, and that's pretty easy to find with a Google search.
I prefer to use just Moderna, just going right to the site. They have a patient fact sheet that's pretty easy to understand. You can also look through the EUA, which is something we provide, and just kind of highlight some of those key pieces as to why people should be receiving this vaccination. And after counseling them and having kind of that one-on-one with anyone who's hesitant over the vaccine, we have seen really great results with that.
So I would say the CDC has, you know, good information. I've also gone to Johns Hopkins. They have a good site. For residents and families, I have to say that, you know, since I'm not directly providing care right now, I would have to defer to other people who are, because, you know, I wouldn't be able to give that. Our professional organization, the American Association of Nurse Practitioners, has a lot of information for us, and they have actually some cases for providers. So it's like a case-based learning example that we can use and, you know, apply to where we are. Also GAPNA, which is the Gerontological Nurse Practitioners Association. And they're the people that I really touched base with prior to this, because they're my colleagues who are working in long-term care presently. So thank you.